Welcome to the PG Track program of Delhi CSI. We are into the 83rd webinar, and we have started currently the new series called the Rapid Fires in Cardiology. The basic purpose is to give you brief, relevant, and deep insights into topics that are of great concern in clinical practice as well as for the exam point of view. In the first session, we had Dr. Satvir Yadav from All India Institute of Medical Sciences. And today we have the privilege of having our dear colleague, Dr. Safal, who is Associate Professor of Cardiology from JVP Hospital. So Dr. Safar is a great guy. He'll be speaking today on assessment of JVP and its correlation with cardiac cycle. Let me tell you, these topics don't aim to give you a complete coverage of that particular topic, but they want to give you a complete insight into the topic that has been decided. The second aspect that is very commonly asked in exams is the hepatojugular reflex. Hepatojugular reflex will also be covered today. And the third one is criteria for diagnosis of Takayasu arteritis. I have on this journey my colleagues, Professor Girish MP, Professor of Cardiology. I also have along with me Dr. Ankit Bansal, Associate Professor of Cardiology. And so over to you, Dr. Safal. In case you guys have any questions and comments, please feel free to message them in the chat box. We'll be happy to answer them. All these topics will be available on your YouTube channel, the PG Track CSI Delhi branch. In case you want any relevant more topics to be covered by any particular speaker, please write to us. And in case you want to join our WhatsApp group, please message to us personally on the set number. So please go ahead, and I welcome you, Dr. Safal. Thank you for agreeing to speak to our many hundreds of residents who join across the country. Over to you. Please take over. Thank you.
Thank you so much for the opportunity, sir.
If you could be loud, your voice is absolutely not.
Thank you so much for the opportunity, sir. Is that loud enough?
Perfect.
All right, sir. Is my screen visible?
Yes.
Okay, sir. So as has already been introduced, three very short topics we shall be covering. And the purpose shall not be to give you an exhaustive knowledge regarding the entire topic. The purpose shall be to just give you enough that you can absorb, that reaches in your reflexes, and that you're able to use clinically as well as in your examination. So rather than exhaustive, these topics will be focused. The three topics, out of these three topics, one is purely theoretical. It is my firm belief that our concentration span is around 30 to 40 minutes. So the clinical aspects I shall be covering first. That is assessment of JVP, its correlation with cardiac cycle, and the hepatojugular reflex. Lastly, I shall be touching upon the Takayasu arteritis diagnostic criteria. So if we are taking a little extra time with JVP and HJR, do not worry, we shall cut things short when we are discussing the theoretical aspects of Takayasu arteritis diagnosis. So starting with JVP assessment. JVP can mean both jugular venous pulse and jugular venous pressure. So what is the difference between the two? The oscillating top of the vertical column of blood in the right internal jugular vein. For practical purposes, it is the right internal jugular vein that is seen. We shall be discussing this also subsequently. But that oscillating top, whose pattern itself you can see, is the jugular venous pulse. And if you measure just the vertical height of that oscillating column, that is the jugular venous pressure. So schematically, this is what the JVP is. Now, if you visualize it as a glass jar, you will not be able to get the meaning of JVP. But just visualize it as a transparent, flexible plastic. You will compress this, this will go up. So this is what the JVP practically is. Now, is it only the right internal jugular vein? Well, it need not only be the right internal jugular vein, but yes, most preferably it is the right internal jugular vein that is used. By and large, you would all be knowing the reasons for it, but still just to recapitulate, these are very basic questions, the answers to which should come reflexly. The right internal jugular extends in an almost straight line, has a direct course to the right atrium, and hence is most likely transmitting the pressures of the right atrium most accurately. Anatomically the closest, and for all practical purposes, it has no valves. Although this statement I shall qualify as we move on subsequently. but for all practical purposes has no valves. So that way, better than the external jugular. So far as why not on the left side, the left innominate is not in a straight line. We see this course that is here, it is not a straight course. And the longer the course, the more chances of it getting kinked or compressed during its course. And so definitely the right internal jugular is what is preferred and is what should be preferred. But then, is it wrong to check the external jugular vein? Now, right and wrong are very blunt statements. And most times in clinical cardiology, something is more right, something is more appropriate, but the alternative is not necessarily wrong. You will see it multiple times in this talk. So definitely the right internal jugular is more appropriate, but checking the external jugular is not useless. It can help establish that the JVP is normal. If the vein is initially collapsed, you can put a light finger pressure at the base of the neck. That will distend it. Now, if this distension rapidly clears once you release the pressure, you can be reasonably sure that the JVP is not elevated. However, if this distension persists, you cannot say that yes, the JVP is elevated. It may persist because of external compression by maybe the cervical fascia or delayed blood flow caused by the valves that we are so afraid of regarding accuracy. So in these instances, it is always better to go for the internal jugular pulsation. Now, the method of examination, I shall be giving it some time because this is vital, and a large proportion of us do not do this correctly, either because we do not see, first and foremost, we know what is correct, then we don't practice it, and gradually the wrong practice, it builds up in our reflexes, and finally we do not do it. And this is one of the major reasons why JVP is not as commonly used as it should be. So the patient should lie comfortably. We shall elaborate on this later. The clothing must be removed from the neck and upper thorax. The neck should not be sharply flexed. It should be gently rotated to the opposite side. Your purpose is to have the sternocleidomastoid relaxed. Again, we shall elaborate on this. The examination is more effective when the room lights are dimmed and you are tangentially shining a light across the neck. Tangentially, not perpendicularly. There should not be any tight bands around the abdomen. And now you start the assessment. Your purpose is that when you are starting the assessment, you are able to see the venous meniscus clearly. Only once you're able to see it clearly, only then you will be able to measure it. Only then you will be able to appreciate the troughs, and only then you'll be able to see its pattern. So now, when can you see the venous meniscus clearly? For most patients, you can start with an elevation of 60 degrees. If your venous meniscus is not clear there, it is not where you want, you can gradually go down by 10 to 15 degrees, and somewhere between 30 to 60 degrees, you will have a point where you can very clearly identify the meniscus. Now, this point that I'm saying, because in your exam, suddenly you will say, I took the JVP at 30 degrees, and somebody may ask, why not 45? So these differences of, once you know your purpose is to be clear, is to have a clear outline of the meniscus. Whether it is at 30, whether you get it at 45, whether you get it at 60, it is immaterial. And these differences of opinion are so much that in the suggested readings, I will be giving you an NEJM article where they said you start from 60. It is 2020 article. They said you start from 60 and then go down by 10 to 15. And then you had a published letter to editor in NEJM where they questioned why not start from 90. So you can start from 60, you can start from 90, as long as finally titrating it by 10 to 15 degrees, you achieve your purpose that your venous meniscus is clearly visible. Neither is 30 wrong, nor is 45 wrong, nor is 60 wrong. If it is, the JVP is markedly elevated, well, you will have to start from the sitting position, have the patient's feet dangling down. It is likely that with venous pooling, you will finally be able to see the meniscus somewhere in the neck. Once you've identified the meniscus, you will obviously both measure the pressure and assess the wave pattern. So coming to each of these points, how do I have a relaxed sternocleidomastoid? Well, and why is it necessary to have it? The sternocleidomastoid, it lies anterior to each internal jugular vein, and when tense, it will impede good observation. So you shorten it and hence relax it. This will permit your meniscus to be clearly visible. How do you achieve this correct position? You place a folded pillow behind the patient's head, the shoulders resting on the mattress. Very gently turn the head away, slightly elevate the jaw. I will just show you how. And let us look at the diagram. Now, just look at this part. Head over a pillow, shoulders on the mattress. And now look at the examiner's palm. The examiner is on the right side of the patient. Slightly rotate it. And from here itself, just a slight tilt that will slightly tilt the mandible up. This will roughly be the position where your SCM will be most relaxed. So, sorry. Now, turning the head away and elevating the jaw, you saw with the examiner's palm very gently. This is often best achieved by gentle pressure of the palm of the observer's hand on the patient's forehead that you have already seen. We are talking about this movement here. Your palm will get this clockwise movement and then a slight pull, slightly elevate the mandible. Now, how much to elevate the head? I think we have discussed in great detail. So for most patients, it will fall between 30 to 60 degrees. The correct angle is that which brings the venous meniscus into the window of visibility between the clavicle and the mandible. Lighting, well, shine a flashlight tangentially to the skin. This is helpful. Casting shadows that improve the visibility of vein motion. With JVP, it is the inward motion, the negative motion that is most clearly seen, unlike the carotid where it is the outward motion. And a tangential light will help you a lot to get it. Dim the room lights, and directing a light perpendicular to the skin is not helpful. Now, the next question you can ask me, do I use the torchlight this way or do I have the torch here and do I use it this way? If both are tangential, both are correct. I'll be suggesting an NEJM video at the end. There you will see the torchlight from this direction. That is immaterial as long as you are focusing it tangentially. So this is about the technique. Now, once you've seen the pulsations, the next question is, are these venous pulsations or are these arterial pulsations? Very standard question. The answer should practically be in your reflexes. There are many differences actually. So, and if you get used to seeing a few JVPs, you'll actually not need to rely on any one thing that it is palpable, it is not palpable. Per se, the pulsations are different. For JVP, it is a soft, diffuse, undulant, like waves actually. Unlike a carotid, which is just a throwout. So it is soft, diffuse, undulant, the nature of the pulsations. It is not palpable. Normal JVP will have 2 crests and 2 troughs per cardiac cycle. The inward motions, as I said, are more prominent than the outward with the carotid. It is obliterated by light pressure at the base of the neck. It has crests that do not coincide with the palpated carotid pulse. Let's just forget the cases of severe tricuspid regurgitation. So both its A and V, those are what are most clearly visible. The A and the V waves will not coincide with the carotid. Again, it will change with the respiratory cycle, unlike the carotid. If you are giving abdominal pressures, it will increase. But you really do not need to go to give abdominal pressures to differentiate the two. Just by the character, just by having 2 crests and 2 troughs, the prominent inward motion, the undulating character, you'll be able to comfortably distinguish between at least a normal JVP and a carotid pulse. Also, a wave whose movement is predominantly downward, predominantly the fall, predominantly the descent, is nearly always venous. So then we come to measuring the level of venous pressure. This is the ideal method. You have, at this particular angle, you have identified that here lies your meniscus, horizontal from here. This is at the manubrium sterni, so this would be around 3.5 centimeters. Add 5 to 3.5, you will get roughly 8.5 centimeters. Now, so using a centimeter ruler, You measure the vertical distance between the angular fluid and the highest level of jugular venous pulsation. The upper limit of normal, for most practical purposes, is 3 centimeters above the sternal angle. So identify the meniscus horizontal from here, and then you place your ruler vertically at the manubrium sternum. Add 5 centimeters. Why add only 5 centimeters? Why not add less? Why not add more? I will come to that a couple of slides later. But conventionally speaking, your viva and case is not going to be only on JVP. So for all practical purposes, you add 5 centimeters. This is a fallacy. This leads to systematic underassessment that we all know, and we shall discuss it subsequently. But as convention, this is what we add. Now, why do we have a systematic underassessment of the JVP, and what is its clinical relevance? The first and foremost is that this underassessment is more marked at higher pressures. So, all right, when the JVP already is elevated, it is possible that your RA pressure is even higher than what the JVP is showing you. It is likely. But for a normal JVP per se, these differences, this underassessment is not so marked. What are the reasons for these? And so practically, as far as measurement is concerned, whether you are getting 11, whether you are getting 12, clinically, that is not of extreme relevance. It will serve its purpose by telling you that the JVP is elevated. But you need to know that in elevated pressures, the pressure that the JVP is telling you, the derived RA pressure, is likely to be lower than the actual RA pressure. Why? As I said, when I was talking about valves, that I will qualify this statement later. Because in a large proportion of individuals, there is at least a functional valve or a valve of variable competence at the termination of the internal jugular vein. And at least partly, it impedes the upward flow of blood and may slightly reduce pressures, the estimated pressures. Also, and then what is the next fallacy? I've already gave you hints in the previous slide, 5 centimeter. So why 5 centimeter at all elevations? Forgive this A, this should be an E. At all angles, you want only a 5 centimeter. Is that correct? So that is obviously not correct. You have references where people have done studies, and most of these studies are in small number of patients. At different elevations, at 30 degrees, it may correspond with, say, around 7 to 8 centimeters. 45 degrees, you actually may need to add 9 to 10 centimeters at 45 and 60 degrees. So, but then as you are having to increase the elevation, I think we are being very clear that yes, we are facing an elevated JVP. Its purpose it has served. Also, in patients who have larger chest AP diameters, it is not going to be 5 centimeters even in the supine position. And smokers in the older age, patients with large BMI. So all these conditions where you are going to have large AP diameter, that 5 centimeters is an underassessment. At least for theoretical purpose, you need to know what is the phlebostatic point. So the phlebostatic point is at the junction of the mid-axillary line and fourth left intercostal space. It has been recommended as a reference point where it will directly correlate with the RA, with the mid-RA, but this also is useful only in the supine position. You need to know it. Practically, already assessing the JVP is a little cumbersome. Making it more cumbersome will reduce its clinical use even more. And so what we do is we take it at the manubrium and we add 5 centimeters. Now, once you've measured the jugular venous pressure, your meniscus is clearly visible. Now you will want to see the wave pattern. And here and in this talk, I shall be focusing only on the normal wave pattern. First, see a few normal ones, or first see a good number of normal ones in fact, and then you will easily be able to identify the abnormal ones. At this stage, having differentials of what is abnormal, or in which conditions it is abnormal will make it a pure theoretical lecture. So first, let us just identify the normal JVP. This looks very beautiful, but this is so beautiful only in theory. I'll actually show you the tracing in practice. It is not so simple and so beautiful. But for the moment, let us believe it is so simple and so beautiful. So what we see here is three distinct peaks: the A, the C, and the V, and 2 troughs: the X, which is frequently divided into the X and X prime, and the Y. Now, mark these words. The A wave represents pre-systolic atrial contraction. So the normal A wave is a diastolic phenomenon. It represents the pre-systolic atrial contraction. It follows the P wave. it is not coincident with the P wave. Mark the word, it follows the P wave, because first the electrical activation occurs, then the mechanical, and that mechanical contraction translates into a rise in pressure. So it follows the P wave on the ECG and it precedes the first heart sound. Each of these is important. You have no leeway to get confused regarding any of these statements. That's why I'm making them so slowly, so gradually. Pre-systolic atrial contraction follows the P wave on the ECG and precedes the first heart sound. The X descent reflects the fall in the right atrial pressure after the A wave peak. It is interrupted by the C wave in ventricular systole as the closed tricuspid valve is pushed up, so the isovolumetric contraction, and the C wave marks the onset of the carotid upstroke. It does not mark the peak of the carotid upstroke, it marks the onset of the carotid upstroke. And according to some, that carotid upstroke may itself have a role in making you discern the C wave. Very frequently, the C wave may just not be discernible. So, the A wave, the X descent, the C wave. It is very difficult to simultaneously auscultate S1, S2, and appreciate the waves in the JVP. The most helpful thing that you have is its correlation with the carotid pulse. So with that, you need to be very clear practically to know what is preceding it, which is the A wave, and what is coming after it. So the onset of the carotid upstroke marked by the C wave. The X descent reflecting a fall in the RA pressure after a wave peak interrupted by the C wave marking the onset of the carotid upstroke. Moving on to the X prime descent. It is the dominant waveform in the JVP. Mind you, it is not the Y descent. I think you've all done it even in MCQs. The X prime is the dominant waveform in the JVP. It follows the C wave due to atrial suction created by ventricular systole, pulling the tricuspid valve down. The V wave represents atrial filling. The V wave is a passive phenomenon and it occurs just after S2. So its peaking will occur after S2. The Y descent follows the V wave peak, and this is due to a passive phenomenon due to fall in RA pressure after tricuspid valve opening. Just for completion's sake, a word about the H wave, a brief positive wave just after the Y and before the A in a long diastole in the diastasis period. Clinically, I do not think you will ever be able to appreciate it. Now coming to correlation with different phases of cardiac cycle, the statements and the words I have done here, written here should be sufficient. I do not think DM or DNP residents of cardiology need a mnemonic for correlation of the JVP. However, this mnemonic is frequently used. So I'm just introducing to it. It is ask me. A, atrial contraction. S, systole for the C wave. K, or the X descent here happening against a closed tricuspid, or all this from C to V, a ventricular systole. V, peak marking the maximum atrial filling, and Y, the emptying of the atrium. Atrial contraction, systole, closed tricuspid, maximal atrial filling, emptying of atrium. Ask me, I am not in favor. So, but if you would actually ask me, I'm not at all in favor of mnemonics, at least at your level. So I have already discussed the most important thing clinically that I have told you is the C wave coinciding with the onset of the carotid upstroke. So the A wave preceding it, the V wave, you can see here, following it down slope. Now, again, these are simultaneous pressure tracings. And again, this is the isovolumic contraction phase. And here is your C wave in the isovolumic contraction phase. So things look simple when they are presented this way. That, oh yes, I will be able to correlate. Things look very simple when they are presented like this. But practically, what presentation do you have? So you are examining a live patient and that patient will breathe. So if you adjust and the changes with respiration will be superimposed on whatever you are seeing. So if you are just wanting to rely that normally the highest will be the A wave and I'll take the highest to be the A wave. If a patient with even a slightly increased respiratory rate, you will not know now what to do now, because this is what it will present. Some of the V's you'll realize are larger than the A's because the inspiratory changes will be superimposed. So practically, it is not as clean and as simple as it looks diagrammatically. Now, why is the JVP so underused? It is clearly visible. It costs you 0 rupees. It is a reflection of what is happening inside the right atrium with certain limitations. But then why is it so underused? It is underused primarily because of lack of training. We do not spend the effort to train ourselves. There is no replacement for practice unless and until during your residency itself, you try to see at least 100 JVPs the right way and make that right way your reflex. What will happen is that you will misassess the JVP. The information that you will get will be unreliable. Subsequently, your confidence with JVP assessment will shatter. With less confidence, you will falsely defend yourself that it is useless. You will underuse it. With further underuse, as you will grow older, your capacity to use it will totally disappear. And that is a vicious cycle. And that is what happens largely. So your residency is the period. It is reliable. It is reasonably reliable. In fact, for the trained, even remote assessment using video chat has been shown to be feasible. If you really want to go through with that, it is the article by Kelly et al. Even remote monitoring, even during video chat, you can reasonably assess, because you don't have to assess every waveform. You just have to assess for most practical purposes whether it is elevated or not. But the time to practice is your residency. There are inherent fallacies, all right. There is a systematic underassessment, all right. But then if it is elevated, it is elevated. JVP plus the abdominojugular or hepatojugular reflex per se in a patient with dyspnea without obvious features of right heart failure have been shown to be variously sensitive and specific. I'll just be quoting one study, 81% sensitive and 80% specific for PCWP, more than 18 millimeter mercury. So this is a useful sign. Where we are lacking is our lack of practice. This is the suggested reading. I think the presentation will be recorded. You can go through it. Very reasonable articles. At least this video in New England Journal of Medicine, you should go through. And some things in the video will be at variation, like where they are shining the torchlight, etc. I have already discussed each of these variations. And at least the NEJM video, the NEJM summary, and the Cleveland Clinic article, I would want each of you to go through. Coming to my next topic, how much time? Okay, I've taken 28 minutes. My next topic, which will be short, the abdominojugular reflex or the hepatojugular reflex. So, is it the reflex? Actually, when I was just editing my slide before starting, one of my very efficient residents had just edited these slides, and I saw that it is reflex written there instead of reflux. So many of us do use the word reflex. As I told you, in clinical science, I do not believe in saying that something is wrong or something is right, but some things are more correct than the others. The HJR or the AJR does not have an afferent limb, does not have an efferent limb. Definitely, for all practical purposes, reflux will be the better word rather than reflex. So let us discuss the abdominojugular reflux. The original definition, a positive AJR is defined by an increase in the jugular venous pressure of more than 3 centimeters that is sustained for longer than 15 seconds, first described by Rondot, 1898. More than 3 centimeters sustained for longer than 15 seconds. This is what it is, but let us go. The variations have come up and acceptable variations have come up. We will see each of these shortly. The prerequisite, obviously, the patient should be positioned such that the JVP can be seen, the venous meniscus can be seen. Also quite obvious is that there should be at least a 3 centimeter margin from the baseline pressure to the angle of jaw, so that you can appreciate that 3 centimeter rise, 3 centimeter sustained rise that you want to see. If the JVP is already markedly elevated, it is practically no use going ahead and doing an AJR or an HJR. Now, after this, you will apply slow, steady abdominal pressure of 20 to 35 millimeter mercury to either the right upper quadrant or the middle of the abdomen. We will discuss subsequently. It's telling me there's something with the audio quality. I hope I'm well audible, sir. I hope I'm well audible, sir.
Yes, sir.
Yes, sir. Yes.
Okay, sir. Now, now we come to, well, you need at least a 3 centimeter margin. Now how much pressure to apply? Slow, steady abdominal pressure of 20 to 35 millimeter mercury, either over the right upper quadrant or over the middle of the abdomen. How do you decide that you are applying 20 to 35 millimeter mercury? Why not more? Why not less? Less will not be useful, will not compress enough. More will be painful to the patient. So the way to practice is you take a blood pressure cuff, put it on the center of your table first, apply pressure, and you will realize how much pressure is enough to generate 20 to 35. However, the surface of the table is hard. It is not like the abdomen. So the idea that you will get from there will be less accurate. Take your BP cuff, put it on your Dunlop, not an exceptionally soft Dunlop, but a usual Dunlop that we use, and 20 to 30, and apply pressures on that cuff. It will tell you how much pressure is adequate. Subsequently, in a stable patient, put that BP cuff across the abdomen of the patient and press. You will come to know at using how much pressure you are able to generate this amount of pressures. After a few cases, you will not need to do this. The pressure has to be sustained for 15 seconds. Now, an important thing is, first, you will press for 15 seconds. Keeping the pressure maintained, you will look up and see whether your JVP has risen, is still showing a rise or not. It is not that you will press for 15 seconds, you will then remove your hands and look up. That is not the case. Keeping the pressure maintained, you will look up and assess whether the rise of 3 centimeters has occurred or not. For most cases, in a normal heart, what you will have is within 3 to 4 seconds, the additional venous return will have been accommodated. So 15 seconds or 10 seconds really does not matter. 10 to 15 seconds, you will get the same result. But please note, you will be assessing it with the pressure maintained, not after releasing the pressure. What is the physiology behind this sign? The abdominal pressure increases venous return to the right heart with a subsequent rise in CVP. In patients with normal cardiac function, this effect is transient, would take only around 3 to 4 seconds to adjust, as the right heart compensates with an augmented right ventricular output. Sustained distension is indicative of failure to accommodate this increased venous return. This can occur with an increase in right ventricular afterload. This can occur with a decrease in right ventricular systolic function. And this can occur in a case of tricuspid stenosis because this preload will not go to the ventricle. And this can occur, it's simply in a case like restrictive cardiomyopathy, just because when the RV compliance is reduced. In a patient where the RV there are no features of RV failure, the RV is normal, presence of an AJR or an HJR is quite predictive of raised PCWP, at least more than 15 millimeters mercury. So coming to the little points, do I press for 10 seconds or do I press for 15 seconds? And what if the examiner asks you, is it 10 seconds or 15 seconds? The original definition was 15 seconds, is 15 seconds. For all practical purposes, 10 seconds will give you the same result. So if you look up your Braunwald or if you look up your NIGM article, 10 seconds is quite acceptable. But yes, the original was 15 seconds. So good to be diplomatic, 10 to 15 seconds. As it is, you're not looking at your clock over there. Next question. Do I press the right upper quadrant or do I press the mid-abdomen? Now, quite controversial. One is both are correct. If you look up Braunwald, they'll say preferably the right upper quadrant. The reason they have not mentioned. If you will ask me, there are two reasons I will say why you should press the mid-abdomen. You get the same results. If you are genuinely doing it in a patient where there's incipient right heart failure, the liver is likely to be tender. One, it is unethical to press in an area where you're likely to elicit pain. Two, that pain will incite a valsalva. And that will make your interpretation very complicated. So it is right. Both are correct. Braunwald says preferably right upper quadrant. My suggestion would be mid-abdomen. That is between the epigastrium and the umbilicus. So with these practical articles done, I shall just be introducing you to the diagnostic criteria for Takayasu arteritis. It is a very crisp topic that I have been given, just the diagnostic criteria. I do not have to discuss the whole of Takayasu arteritis. This should be simple. Each of these criteria are very difficult to learn, but if you get Takayasu arteritis as a case, you will have to know each one of them. There is no doubt about it. So let us start with Ishikawa's criteria. The details over here, I will not be reading out because by the end of it, those of you who have not already fallen asleep will fall asleep. So I will just be reading out the criteria, the major parts from here. So the Ishikawa's criteria, their biggest criticism also is that they have the obligatory criterion of age of onset less than equal to 40 years. Age less than 40 years at diagnosis or at onset of characteristic signs and symptoms of 1 month duration in the patient history. In almost all series, you will see roughly around 10 up to 10% of the patients will have their onset after 40 years, but almost nobody after 60 years. So this is its biggest criticism. A good number of patients who have no alternative diagnosis, it starts ruling out just because of this age criterion, Takayasu arteritis. We shall see the Sharma et al.'s modification subsequently to this. Now, apart from the obligatory criterion, it has two major criteria: left mid-subclavian and right mid-subclavian artery lesion on angiogram. 9 minor criteria: raised DSR more than equal to 20. The mid-subclavian definition is here for you to read. The 9 minor criteria: raised DSR, unexplained persistent high SR more than equal to 20. Carotid artery tenderness, mind you, carotid artery tenderness, not neck muscle tenderness. Hypertension, again at age less than equal to 40 years. Hypertension or history of hypertension at age less than equal to 40 years. Less 140 by 90 brachial, 160 by 90 popliteal. Aortic regurgitation, evidence by auscultation, Doppler or angiogram. Annulo-aortic ectasia by angio or 2D echo. Pulmonary artery lesions, left mid-common carotid lesion. Distal, that is distal 1/3 brachiocephalic trunk lesion. Descending thoracic aorta lesion and abdominal aorta lesion, all the minor criteria. And in the abdominal aorta lesion, you'll have to see narrowing dilution, aneurysm, luminal irregularity, any combination, and absence of lesion in the aortoiliac region consisting of 2 centimeters terminal aorta and bilateral common iliac. So to fulfill this criterion, they should have no aortoiliac disease, no iliac disease. Obligatory plus 2 major, obligatory plus 1 major and more than equal to 2 minor, or obligatory plus 4 or more minor would suggest a high probability of Takayasu arteritis as per the 1988 Ishikawa criteria. Now, the shortcomings were pointed out by Sharma et al. Sequence-wise, the Ishikawa came first, 1988, followed by the 1990 ACR criteria, followed by the Sharma et al. Modifications in around 95. But I will just to maintain continuity, I will discuss the modifications first. So using a series of 106 angiographically proven Indian patients, Sharma et al. Proposed the following modifications: removal of the obligatory criterion of age less than 40, inclusion of characteristics, so there is no obligatory criteria, inclusion of characteristic signs and symptoms as a major criterion, removal of age, again from both places they have removed age of 40 cutoff, removal of age in defining hypertension, deletion of the absence, that prerequisite of absence of aortoiliac disease was there, they have removed that, and addition of coronary artery lesion in absence of risk factors, practically addition of coronary artery lesion in somebody less than 30 in absence of risk factors. So these are their modifications. No obligatory criterion. Instead of 2, now you have 3 major criteria here: left mid-subclavian, right mid-subclavian, correct, and then characteristic signs and symptoms of at least 1 month duration, including limb claudication, pulselessness, pulse differences in limbs, unobtainable or significant BP differences more than 10, fever, neck pain, transient amaurosis, blurred vision, syncope, dyspnea, more than 1 month duration. Again, in the clinical features in 1 major criterion, and from abdominal aorta lesion, that prerequisite of not having iliac disease is out. Coronary artery lesion documented on angiogram below the age of 30 years in absence of other risk factors like hyperlipidemia or diabetes mellitus. Presence of two major or one major and two minor criteria, or presence of four minor criteria suggests a high possibility of Takayasu arteritis. And from their paper, if you will see, in their 106 patients, the sensitivity of Ishikawa was 60.4, ACR criteria 1990 was 77.4, and their sensitivity was 92.5. Now, whenever you read any kind of criteria, you must be aware that there are two cohorts in which a criteria is actually to be developed. One is the cohort in which it is the derivative cohort, in which it has to be developed, in which it has been developed. The other is a validation cohort. So whether you are talking about these criteria or you are talking about ventricular tachycardia criteria, you need to know that the derivative cohort from where these criteria have been developed, all of them in their own cohorts have sensitivities well above 90%, specificities well above 90%. But when they are tested in a different cohort, usually sensitivities go down, specificities go down. This is for almost all criteria. So in their own series, all right, they have a sensitivity of 92.5%, and ACR and Ishikawa have sensitivities of only 77.4 and 60%. But truly the test of the criteria will be when they are tested in a different cohort. Let us see the most commonly used, the 1990 criteria for classification of Takayasu arteritis. Sensitivity 90.5, specificity 97.8%, for more than equal to 3 being present. Nothing obligatory. It does have age at onset less than equal to 40 years as one criterion, but it is not an obligatory criterion. Claudication of extremities, decreased brachial artery pulse, BP difference more than 10, bruit over subclavian, and arteriogram abnormality, arteriographic narrowing or occlusion of the entire aorta, primary branches, or large arteries in the proximal upper or lower extremities, not due to arteriosclerosis, FMD, or similar causes. Changes are usually focal or segmental. If you are getting a Takayasu arteritis case, these criteria should be at the tips of your fingers. Now, this is for adults. For children less than 18, we have a separate derived Euler Printo Press childhood Takayasu criteria in a sample population of 1,056 with those with age less than 18. Just to enumerate, the criteria will be angiographic abnormality, which is mandatory. It may be conventional, it may be CT, it may be demonstrated by MR angiogram. And followed, in addition to this, the other criteria include pulse deficit, BP discrepancy, bruit, hypertension, and raised acute phase reactance. Now, angiographic abnormalities of the aorta, its main branches and pulmonary artery showing aneurysm dilatation, mandatory, plus any one of these five will, any one of the five following criteria: pulse deficit, four-limb BP discrepancy, bruit, hypertension, acute phase reactant. So this is the 2008 Euler Printo Press for childhood Takayasu arteritis, valid for those less than 18 years. Now, the 1990 ACR criteria are obviously too old. Number of limitations, and obviously the most important limitation is with MR angio and CT angio being having come up so much in the past 3 decades. These criteria not having been revised is just not acceptable. Revision is underway. There is a point-based risk scoring system that has been suggested. The draft has been presented. I will not be going into its details because it has not yet been approved, and maybe by the time it is approved, some minor modifications are made to it. But practically speaking, it is a point-based scoring system. Approval is expected anytime, and most likely, at least those of you who are in first years, by the time you will appear for your exam, the SCR criteria will have been revised. And this is robust because this is what they have done. This is the development cohort, 639 patients. In that also, they have shown a sensitivity, specificity of over 90%, and then validated it over another 273 patients. There also sensitivity, specificity are fairly high. It has 3 mandatory criteria that have to be met: diagnosis of vasculitis, less than equal to 60 years age at diagnosis, and evidence of vasculitis on imaging, followed by more than 5 points from those below. I'm not going into the details because maybe by the time they're actually approved, there are some minor changes to it, but they're expected soon. Beyond diagnosis, you'll also be asked the angiographic classification of Takayasu arteritis. The Takayasu Conference Classification 1994 is what you need to know by rote. Type 1, branches from the aortic arch. Type 2A, the ascending aorta, arch and branches. 2B, ascending aorta, arch and branches, thoracic descending aorta. 3, it's excluded the ascending aorta and arch, so the thoracic descending aorta, abdominal aorta, and renal arteries. Type 4, abdominal aorta, renal arteries only. Type 5, both 2B and 4. Where there's coronary involvement, add C. Where there's pulmonary involvement, you add P. And for completion's sake, you also have the Ishikawa clinical, not diagnostic, classification criteria of Takayasu. Group 1, uncomplicated disease with or without pulmonary involvement. Group 2, a mild, moderate, single complication together with uncomplicated disease. 2B, severe single complication together with uncomplicated disease. Group 3, 2 or more complications together with uncomplicated disease. For those of you who are still awake, thank you.
I think nice presentation, Safal. Actually, very lucidly illustrated most of the things. And just to add on to what Safal has already told us, maybe one more important structure in the neck is cervical fascia. So one should ensure that it is not an active movement of the patient neck. It has to be supported by the examiner. So that is more important. So sternocleidomastoid and cervical fascia. These are the two structures which have good amount of tone in the neck. So those need to be relaxed before starting an examination of jugular venous pulse. And the fallacies and other things about jugular venous pulse has been very clearly and emphatically told by Dr. Safal.
Any other questions, Ankit, or any other comments that you have?
Sir, I have little bit confusion about the abdominal jugular reflux. So actually, if the reflux, it is very difficult for the candidate to simultaneously press and simultaneously measure the increase of 3 centimeter. So can we do like this? We point out, we make a marking of the baseline pressure at the neck and a 3 centimeter height just above it. And we can make a mark over the neck or over the internal jugular vein. And if the meniscus rise above that mark, then we can say that it is rises of more than 3 centimeter, because he is maintaining pressure with the right hand on the abdomen. Then he has to measure the 3 centimeter rise also. But so in the books, it is not.
There is one thing. There is one thing which is very clear, that the rise in the JVP is not always simultaneously with, or it does not always require the pressure to be sustained. The rise in JVP itself is sustained. So probably the measurement can even be done when you are just withdrawn the hand also. Okay. So because
basically in the books it is written that you have to measure while you are giving pressure. So if you do not measure, because there are some variations of HJR also, what we can say that if the pressure is the rise in pressure is of 4 mm of Hg, but it is not sustaining for 15 seconds, then will it be positive or will it be negative?
It will not be then considered as positive. It will be considered an intermediate response, not a definitive response. It requires both things to be fulfilled.
Yeah. So we have to measure 3 different things. We have to give pressure. We have to measure the height of the column, the rise in the height of the column, and the duration. So a candidate has to give measure the time, measure the pressure, and also give the simultaneous compression. So it will be very difficult for one candidate to do all these three things simultaneously.
I will totally agree with you. See, whether it rises by 3.5 centimeters or 4.5 centimeters is immaterial. It just has to rise by more than 3 centimeters. Also, when we are placing our patient at that point itself, we have to decide that we have given it enough margin that is visible so that a rise in 3 centimeters will be seen. So that point should be Exactly. Marked is not the word I will use, because some patient examiners will say, why are you marking on the patient? But that point can be predefined, will be predefined. The moment you are saying that, you are giving a 3 centimeter margin where the meniscus will be visible. And if it reaches that point and at 15 seconds or 10 to 15 seconds, it is at that point, we can say it is a positive HJR.
Yeah, because books say that you have to measure while you are compressing. That measurement is not possible while we are compressing.
With a single person, it is not visible.
Yeah, we can only see whether it is
Just touch your predefined point.
touch that mark or not touching that mark.
Well, you had shown multiple criteria for Takayasu arteritis. They obviously seem very exciting, and for exam purposes, people have to remember so many things and criteria. Which one do you think are actually more relevant for exam? I still believe that the classical one is the ACR criteria, which one they should be definitely knowing. Sharma's modifications are also to quite an extent are asked, and then the classical criteria. But otherwise, there are so many scores that you have shown that they have come up now. So how much and clinical relevance and how much validated they are. So generally, I am not aware of them, to be very honest with you. So that's just for the completion's sake that one should be just aware of their names or something.
So the ACR criteria are a must. And they are the most scientifically developed. And the point-based scoring that I had shown till today, they do not need to read it. But if the modification gets approved, then by and large, that will be the most validated. But as of today, the ACR criteria, yes. Ishikawa, I would say, is more of historical reference because relevance, because it was the first that was given. But if at all beyond ACR, it will have to be the Sharma et al.'s modification.
I think, Girish, any other things? I would strongly suggest that hepatojugular reflux is an article by Dr. Weiss in American Journal of Cardiology. It's a very beautiful, comprehensive article, 3-page article that gives you. I'll post it on the different groups, and you guys can just go and read it about the various nomenclatures of hepatojugular reflux. What are the nuances involved? What are the etiologies involved? Why this is reflex and not a reflux? What are the 4 theories of causation of hepatojugular reflux, as Safal was highlighting, and what are the hemodynamics? Remember that correlation of hemodynamic from each sign is very, very important. How is it contributing? Like Dr. Safal showed that when you are combining JVP and hepatojugular reflux, it gives you a sensitivity and specificity almost going to equivalent to 80%, 81%. Another thing is that, there is a double index also, double dyspnea index also, that is a new nomenclature that was published in the JACC article of approach to clinical examination in heart failure. That is also another must-read article when you are talking about JVP and hepatojugular reflux. So both these things I would strongly suggest from your exam. It's a mandatory, it's a must-read article for all the fellows and the residents. So each finding has a definite correlation. Like, some examiner would like to ask you that if JVP is raised when you're sitting at posture 90 degree, so what would be approximately RA pressure? So you should be just having an idea. It should be somewhere around about 25. So these are the standard questions that people and residents and fellows are asked, and sometimes we fumble. So these articles will give you a much beautiful insight into these. The purpose of this activity is just to stimulate your minds to read and complete all the preparations for your exams and also for your clinics. So we are trying to balance out both the clinical examination, which is important for your passing also, and then also some important features for your practice criteria. So next week, I think we'll be coming again with 3 new set of presentations, again aiming to provide you some deeper and great insights, focused insights on relevant topics. And in case if there are no further questions, I think Dr. Safal, I must thank you on behalf of the CSI Delhi, and my colleagues will agree with me that it was definitely a terrific and a great presentation. Very lucid, the way you explain, go straight into the brain of the people. We have almost 320 people who are live online today with us, residents, and it was such a pleasure to hear with you. Hope to catch up soon sometime with you. We'll invite you more for our future sessions. And thank you, Girish. Thank you, Ankit. And thank you all the residents and fellows. We'll be posting this lecture again tomorrow on the PG Track CSI Delhi branch channel. I think there's some questions, Girish, that have come up. I just saw them.
No, it's I think nothing very significant.
Okay.
So the question is they're asking whether it should be done only when the baseline, you're not able to see the JVP. So that is already accepted. So it's a known thing. I think, and one more thing which Safal has beautifully covered is the person who was described abdojugular reflex for the first time. It's also named after him. That is Rondout sign.
Rondout.
So suddenly someone asks, so what about Rondout sign? So you should not be surprised.
Taken aback. Rondout sign, Pasha, Rondout sign. There are 4 different ways you can. So it was a great presentation. Thank you, everybody, and we'll catch up next week with 3 different topics. And have a safe weekend. Stay safe and enjoy your academics. Thank you so much. Good evening.
Bye.
Yes, sir. Thank you.